Okay, Assalamu alaikum. This is a case where we have upper and lower impressions. I'm going to talk about the effect of knowing the anatomy on the evaluation of the impression. What you need to know is that the labial sulcus is the labial ridge first, the first section of the labial part of the ridge is usually thinner than the posterior. So that's why we place less material here. Once we take the impression, the labial sulcus here almost is a bit deeper. The most deep point is on the premolar area. Then it goes back to be shallow. So the premolar area is the deepest on the buccal. Okay. Some patients we have the labial the deepest if the most recent extracted teeth are the labial teeth or the anterior from canine to canine. That means the bone is still there. So it depends on the history of extractions, but usually the labial sulcus is shallower than the premolar area if they have been extracted exact around the same time. But what I want to concentrate in the lower here is the S shape. You can find that the lingual pouch is deeper than the lingual frenum area. This is what I'm concentrating on. And when I measured it inside the patient's mouth, when I take a measurement from inside the patient's mouth, I put my finger on the retromolar pad, then I go down. The tongue should be on the upper lip. I noticed how much my finger entered, and then I compare it with the same side and I took it all. So there is no shortness. If it was like this, that means it's short, I need to add material. But here, the anatomy is telling me that this impression is correct, and the actual measurement is telling me it's correct. So once more, the labial, the most deep areas are around the premolars, then they become shallow because the mesenteric plane, while the lingual pouch is deeper than this side. So the anatomy is telling me that the impressions are correct, other than the other features that you've seen in other videos. Here I'm concentrating on the anatomy. What made me make this video better was the anterior area. Posteriorly, you can see that we have this posterior area, the sulcus is round and smooth. I need to measure this from inside the patient's mouth, so I take a measurement. I go distobuccally from the tuberosity. You will see it in other videos in more detail. How much did my finger enter? This is the amount. I invert it and measure, then it was taken correctly. The other side, by the way, the left should not be like the right. If this has been recently extracted, it will have more bone. So it doesn't mean that the tuberosity on the left is the same as the right. I'm going to the other side. So once more, from the tuberosity, I go distobuccal. Inside, I take the measurement and I compare it. 1 millimeter shortness is okay because this is where my finger was. 1 millimeter shortness is okay. We will take it in the secondary patient. But more than 2 millimeter or more, I need to add. I add compound, as you have seen in other videos. What I'm doing this video for is the anterior. The anatomy is telling me that you have not taken the anterior area correctly, where I see that the labial sulcus is very shallow. In the upper, the labial sulcus is deeper than the premolar area. This is how it should be, unless we have the combination syndrome. And this is a specific syndrome where we have specific features. And this patient doesn't have a combination syndrome from intraoral examination. So the anatomy is telling your impression is incorrect. Why? The labial sulcus should be deeper than the premolar area. Okay? So the labial sulcus is very shallow here. First, I want to discuss why this happens. The second, how to treat it. Now, first, why did it happen? Because there is not sufficient material here. You see it's very thin. That means the tray, while entering, it hit the ridge. So you were too close to the ridge. The tray was too close. So it hit before entering around. Okay? It hit part of the ridge. This hit will drag the material away and also will not take the sulcus correctly. To take the sulcus correctly, if this was the ridge, if I have the ridge here, I should go front of the ridge around 1 centimeter. While I'm rotating, it will go back, come closer. You're okay. You're going to go back close to the ridge. But then when you go by rotating closer, you will have sufficient material to go in the sulcus and you will not have this hit. Okay? So you see this is shallow. Another way so the anatomy is telling me the impression is incorrect. Another way to do it is compare. Simply see how deep the ridge is compared to the sulcus. Let's see it inside the patient's mouth. So once more, if I'm stretching the tissue, see how much attached gingiva I have? See how much deep it is? This is how much my finger entered. This is how much my finger entered into the labial sulcus. Where is that here? It's deficient. It's very deficient here. So how am I going to do it? Now, how to repair it? You have 2 ways to repair it. Either to heat it all together and go back and put it once more in the correct position. Another way, if you want to be quick, bring 1/4 of a cake, melt it until it's soft, and then add it as border molding. And with your finger, when you take it inside, this will act as a tray because it's hard. The new material is soft, so it will support it. It will push itself into the sulcus, and by your finger adapt it into the sulcus. Then do the border movements and make sure you record the labial correctly. So two things told me this is incorrect. First, the comparison of the labial sulcus in comparison with the premolar and molar area, and the second is comparison from inside. Thank you.